here. I'm here only. I'm here.
Yeah, super.
Ma'am, you can start. Hello. Ma'am, you can start the session. Hello. Hello.
Yes, Asmita.
Sir. Hello, Joy, sir.
So I think we'll just welcome everyone. Good evening, everyone. It's a pleasure to have you all here from the sleep disorders subsection of the neurology. And we today are privileged to have Dr. Sapna with us. She's a professor of neurology at the Sri Chitra Tirunal Institute of Medical Sciences. Her area of specialization is stroke and sleep medicine. And today she'll be talking to us about something novel about this sleep apnea. Over to you, Dr. Sapna. Thank you for being here.
Thank you, Manmeera ma'am. Shall I share the slides?
Yeah, please start. Please start.
Is my slide visible, ma'am?
Yes, yes, it's visible.
Yeah, okay. So, first of all, thank you, Manveer ma'am and Joyce sir, for giving me an opportunity to present on this, as madam mentioned, novel topic. So, as physicians, we see different types of OSA in our daily practice. So, this is being increasingly recognized nowadays in the scientific literature as well. So, I hope this brief presentation of 20-25 minutes will help you in improving your understanding of the different OSA phenotype and why people behave differently. So my outline of topic would be what is the conventional understanding of OSA? Why? What are the pitfalls in relying on the apnea-hypopnea index alone, which we use for diagnosing OSA? What are the different clinical phenotypes which we see in practice? Very briefly about the pathophysiology, PSG predictors, what is its impact on cognitive health and cardiovascular health, and impact on therapy. So we learned OSA as a condition characterized by repetitive upper airway collapse during sleep, which results in repetitive hypoxemia, hypercarbia, catecholamine surge, sleep fragmentation, and autonomic changes. So these result in major cardiovascular and neurocognitive sequelae down the line. As per the International Classification of Sleep Disorders 2012, ICST-3 classification, obstructive sleep apnea hypopnea syndrome is diagnosed when you have symptoms, which can be nighttime symptoms or daytime symptoms, along with the AHI number, which is derived after doing a polysomnography, which is 5 or above. Or if AHI is 15 or above without symptoms also, you can diagnose the condition as obstructive sleep apnea hypopnea syndrome. So our understanding is OSA usually affects middle-aged obese people. Men are more prone to have OSA. They have severe snoring, significant sleep fragmentation, and daytime sleepiness. But when we sit in clinics and see patients who come for sleep evaluation, not all patients are of the typical phenotype. There are patients, females who are not very obese, who present with significant sleep fragmentation and refreshing sleep. Then you have people with craniofacial abnormalities like retrognathia, who have significantly disturbed sleep snoring. Then pediatricians refer to sleep physicians for children with some syndromes like Prader-Willi syndrome, Down syndrome, etc., with airway obstruction and sometimes hyperactivity or excessive daytime sleepiness. And we also know that even if the AHI numbers are comparable, the health and safety impacts differently among different patients. Because some of our patients have significant daytime sleepiness, disturbed night sleep, but some of them surprisingly have very less symptoms, even though the AHI numbers may be 15 or above. And also, when you look at the vascular risk factor profile, some of the patients have significant vascular comorbidities like hypertension, cardiovascular disease, whereas many patients have very minimal vascular comorbidities. And also, when you look at the PSG parameters, you can find for the same number of AHI, some people have significant hypoxemia, whereas some people have very minimal hypoxemia, whereas the sleep architecture is more or less stable, whereas some people have a very high sleep fragmentation and arousal threshold. So this leads us to this question that there are a lot of differences in their pathogenic mechanisms, physiological impact, and disease expression of same condition, obstructive sleep apnea. So this has led to people working in this area look critically at the index, that is apnea hypopnea index, which is used as a gold standard for defining OSA. Previously, in the beginning, when this disease was described, mainly apneas was included in the definition. Later, we know that hypopneas are also significant. Then there are other events like respiratory effort-related arousals, which also produce significant sleep fragmentation and autonomic dysfunction. Then the rating of the apnea hypopnea index, the numbers can be affected by different factors. And also it may vary from night to night, and also it depends on the expertise of the evaluator. And also we know that the AHI, as I mentioned, fails often to capture the exact disease state or the severity of an individual disease condition. So even though still AHI, because of want of other metrics, still is used as a gold standard for diagnosing and measuring the severity of OSA, we know that it may not truly reflect the disease state of OSA. So we looked into our experience of clinical and polysomnographic predictors of severe OSA in South Indian population. So this was done in 2016. So we looked at 1 year data of patients undergoing polysomnography, 152 subjects who had mild to moderate or severe OSA. So we found that surprisingly 11.8% of our patients had insomnia as a main complaint as opposed to daytime sleepiness. And when we ask history of patients with suspected OSA, we often mention that excessive daytime sleepiness is one of the most important symptom, but only 2/3 of our patients had excessive daytime sleepiness, which means that about 1/3 did not have excessive daytime sleepiness when they presented to clinic. And also, about 36% reported that they got a good night's sleep and woke up refreshed after the overnight sleep. So we found that older subjects with witnessed apneas were more likely to have severe OSA. Overall sleep architecture was similar between the moderate and severe OSA groups. However, severe OSA group had a shorter slow wave sleep, long duration of apneas, and higher nocturnal hypoxemia as expected. Now coming to the endophenotypes of OSA. So the first literature about the phenotypic expression, difference in phenotypic expression of OSA was from Icelandic cohort, which was published in 2014. So here they looked at 822 subjects with moderate to severe OSA from a single population. And they found that based on the symptom cluster, they had 3 different groups of manifestation. So cluster 1, this was a disturbed sleep group, which constitute about 1/3, that is 32.7% of subjects. Then the next group was minimally symptomatic group, which is a cluster 2, which had about 24.7% of subjects. And the excessive daytime sleepiness group, which was a cluster 3, which is the variety which we think as a garden variety of OSA, was seen in only less than half of the subjects, that is 42.6% of subjects. In this Icelandic cohort, they found that they looked at the vascular comorbidities and their association with this cluster. So they found that the probability of having comorbid hypertension and cardiovascular disease was highest in cluster 2, but least in cluster 3. But the subsequent studies from the Global Sleep Apnea Registry as well as from the Sleep Heart Health Study have had contradictory results. In this Icelandic cohort, they found that the clusters did not significantly differ in terms of gender, BMI, or apnea-hypopnea index. So that is for the same AHI numbers, you can find that the clusters, there are 3 different different phenotypic expressions in OSA people. And as I mentioned, the vascular risk factors can find that hypertension in this cluster was more in cluster 2, that is a minimally symptomatic group, than in the cluster 3. COPD was more common in cluster 3 when compared to cluster 2. Now, is it confined to Icelandic cohort alone, or we can find it in other population as well? So this is a study published about 4 years later. This is from the Sleep Apnea Global Interdisciplinary Consortium study. So they had subjects recruited from different parts of the globe, including from Asia. So they had about 972 subjects with moderate to severe OSA. They looked at about many symptom variables as well as risk factors in their population. So here actually they identified 5 clusters. So it is getting more confusing. So cluster 1 is similar to the Icelandic cohort of cluster 1, disturbed sleep symptoms. So this was the subgroup which exhibited maximum disturbance in sleep. So they had difficulty in falling asleep, difficulty in maintaining sleep, waking up too early, and also they reported unrefreshing sleep. And this cluster had the highest rate of hypertension, diabetes, and cardiovascular disease. Now coming to the next cluster, cluster 2. So this was a group with the minimal symptoms, which was comparable to the cluster 2 of the Icelandic registry. So this group was, despite having moderate to severe OSA, that is AHI numbers above 15, this group had very less excessive daytime sleepiness, and 3/4 reported that they had a feeling of refreshed sleep on waking up, and even 1/4 reported no snoring. So many of them were evaluated for either refractory hypertension or other vascular comorbidities, and because of that, they underwent a sleep study as well. So this may be the subgroup who are highly resilient to the usual clinical symptoms of OSA, and thus the disease impact may not be reflected by our measured symptoms. Now coming to the cluster 3, this is similar to the cluster 3, that is excessive daytime sleepiness group in the Icelandic cohort. So they had upper airway symptoms along with excessive daytime sleepiness. And the average Epworth sleepiness score, which is used for measuring daytime sleepiness, was about 16 in this group. And a quarter reported drowsiness while driving. And this group also reported high rate of upper airway obstructive symptoms like snoring, witnessed apneas, and waking up with the witnessed apneas or difficulty in breathing. Now they also identified two more clusters, cluster 4. The cluster 4 was a group which is dominated by mainly symptoms of upper airway obstruction. So they had very low rate of excessive daytime sleepiness or insomnia related symptoms. They mainly reported for pure snoring or witnessed apneas. And this group were younger and they had less of vascular risk factors like hypertension, diabetes, or cardiovascular disease. Finally, cluster 5, which is about around 20%. This was a group who were older, who mainly reported only excessive daytime sleepiness, but they did not come forth with upper airway obstructive symptoms when asked. So they had a significant daytime sleepiness and drowsiness while driving. They tended to take a lot of naps in the daytime, but they had low rate of, or they did not report significant upper airway symptoms. So when the Icelandic cluster was compared with the SAGIC registry, that is the Sleep Apnea Global Interdisciplinary Consortium registry, it was found that the cluster 1, 2, and 3 were comparable between the Icelandic group, whereas the other two clusters, there was a mix with the Icelandic registry. So what is the take home from this study is that as Asians, in Asian population, there is a difference in the phenotypic expression. So this was reflected in the SAGIC study as well. So they found that cluster 4 was more in Asian population. And they found that their patients were younger, they had less of daytime sleepiness, but they had more of upper airway symptoms. So the cluster 4, that is the upper airway symptom dominant cluster, were younger, less obese, and more participants in the Asian ancestry were found, whereas disturbed sleep cluster were more obese and also older. So is there a difference in their cardiovascular risk factor as well as long-term cardiovascular outcome depending upon their phenotype? The sleep heart health study, which have done a lot of which has done a population-based study using sleep polysomnography in US, they identified based on the symptoms actually 4 clusters. So subsequently, most of the studies after 2019 have used this model, that is a 4-cluster model, for explaining the phenotype of OSA. So these are, one is a sleep disturbed group, the second is a minimally symptomatic group, then severe sleepiness group, and they had a 4th cluster, which is a moderately sleepy group. So they compared these subjects with more than 2,000 individuals with the AHI less than 5 and followed them up for their cardiovascular comorbidities. So they found that this orange line indicates the excessively sleepy group. So the excessively sleepy group had a higher incidence of coronary artery disease, higher incidence of heart failure, but the stroke incidence did not significantly differ between the two groups. So just briefly about the pathophysiology behind this phenotype. So we know that in OSA, there is an anatomical compromise, which can be due to a combination of many factors like obesity, craniofacial structures, lung volume, fluid shift, nasal resistance, upper airway surface tension, etc. And on this, there are main 3 important non-anatomical factors which will act. So they are an oversensitive ventilatory control system, which is a high loop gain. Then there is a low arousal threshold, respiratory arousal threshold. And the third mechanism is a poor pharyngeal dilator muscle tone or responsiveness during sleep. So in 100% of subjects, there is an impaired anatomy of varying severities. And on this, These three mechanisms act, which may be an ineffective upper airway dilator muscles, unstable ventilatory control, and a low arousal threshold to produce the repetitive airway collapse which occur during sleep. So when you measure apnea-hypopnea index alone, you are unable to measure many of the underlying pathophysiology behind the OSA. So some of these can be used by some surrogate markers from polysomnography or CPAP titration. For example, the airway collapsibility or the peak, that is a critical pressure, can be indirectly correlating with the CPAP pressure requirement. So that means that if there is a very low airway collapsibility, means the CPAP pressure requirement is usually low, less than 8 centimeters of water. Then another is looking at the arousal threshold. Because when we report polysomnography, we can find that there are some people who have very significant arousals during sleep, but some people with the same AHI metrics may not have significant arousals. So arousal threshold can be measured by non-invasive polysomnography calibrated, uncalibrated ventilatory signals like nasal pressure measurement, along with clinical scoring of the arousals. Then the pharyngeal muscle tone. There are some people who have a low non-REM sleep AHI, whereas a very high REM sleep apnea. So this may be an indicator that their pharyngeal muscle tone is better during, which is normally better during NREM sleep. Then another way to measure, indirect measure of the airway collapsibility is looking at the fraction of hypopneas to apneas. If the hypopneas are more, which indicate that the airway collapsibility is low, whereas if the apneas are more, which indicates that the airway collapsibility is high. Then another measure is using an arousal threshold. So ideally, you need an epiglottic pressure sensor to measure the arousal threshold. Then there are some EEG-based metrics of sleep stability, which can be used to measure sleep disturbances, which are described in literature. Then another measure in PSG that is often reported, which may be correlating with the cardiovascular comorbidity, is the hypoxic burden. So roughly it indicates the area under the baseline, that is a saturation below the baseline per hour of sleep. So higher the hypoxic burden, more risk of somebody to have a cardiovascular comorbidity or a cardiovascular complications. Now, the next question, which as neurologists we face, is whether this phenotype has an association with the cognitive function. Because we know that many of our subjects present to us with daytime sleepiness, mind forgetfulness and all. When we evaluate polysomnography, we find that they have moderate to severe OSA. So there are studies regarding this are limited, but a study from Canada which looked at the endophenotype and their cognitive performance could not find an association between the cluster analysis in the excessively sleepy group, moderately symptomatic group with their cognitive performance. So now the last part, how does it impact our decision for treating the patient? This is very important because in OSA, we know that once we make the diagnosis, we prescribe CPAP. But many of the time, the patients are not compliant to CPAP or they stop using CPAP after a few months to years. So when you look, when you follow them up of 1 year or more, you can find that the CPAP compliance is very poor, less of the order of less than 50% in many of the patients. So has it something to do with the phenotype of OSA? So what is the Icelandic cohort, when they were followed up with CPAP therapy, it was found that in the disturbed sleep group, when they followed up, the insomnia symptoms still persisted despite adequate CPAP usage. In the minimally symptomatic group, since they were having minimal symptoms at baseline, the subjects did not experience any significant symptom change with PAP, except there was a mild improvement in daytime tiredness with CPAP therapy. However, in the excessively sleepy group, it was found that they were more adherent to CPAP therapy because of the maximum benefit. And when they looked at the whole cohort, CPAP compliant versus CPAP non-compliant group, they found that the PAP compliant group had a better night sleep, less daytime sleepiness, and they were more alert while driving. However, the another question is whether this compliance translates to better cardiovascular outcome. So far, many of the randomized trials, including SAFE study, was negative regarding whether even CPAP usage improves the long-term cardiovascular or stroke mortality. So here in this cohort, they found that a mild BP reduction was achieved in minimally symptomatic and moderately symptomatic group at 2 years after BiPAP, but it was not coming to be statistically significant. So the treatment of OSA is a big topic in itself. So I will be just touching upon the basic principle. So if there is a major anatomical impairment, like a significant obstruction, then a major anatomical interventions like surgical treatment may be required in OSA, which is the personalized medicine. Whereas if there is only mild anatomical impairment, like if there is a low arousal threshold, then there are studies which have explored the use of medications to improve arousal threshold. Then to play with the loop gain, people have tried on acetazolamide for mild OSA. So these are the other emerging therapies which may be coming, which may help in replacing or even as an add-on therapy to CPAP. So this is the last slide. In the past, we thought of OSA as a single condition where patient had excessive daytime sleepiness, disturbed night sleep. They were mostly obese people. And we diagnosed it with the polysomnography with the measurement of apnea-hypopnea index. So if the numbers are significantly higher, above 15 or above 5, you make a diagnosis of OSA. You prescribe them with CPAP therapy and forget it. So at present, we know that it is not as simple. You have different phenotypes. Some people have significantly disturbed sleep, whereas a subgroup have minimal symptoms. There are a subgroup of people who are excessively sleepy, and generalizing all the people to a single treatment may not work. So what future holds is in precision medicine in this subgroup. So depending upon the basic pathophysiology of OSA, in future, we may be able to tailor specific treatment for individual patients. Thank you.
So thank you, Sapna. That was really very elaborate and quite insightful. So maybe if there are questions from the audience, we could take those first before I have a couple of things to ask, but I will reserve that for the end. Wonderful. Really enjoyed that. Asmita, is it possible to take up questions from the attendees? Asmita, you there?
Yes, sir.
I don't think there are questions, sir.
Yes, sir, no questions.
Yeah, all right. Okay.
I'll just make a comment, then we can. So I just wanted to thank Dr. Sapna again. And just for the attendees, for people who have been seeing sleep apnea or are still seeing sleep apnea, I think this is a really new domain and a realm and to enter into this. See, because we as neurologists now, everybody understands the numerous, all headaches are not one, all Parkinson's disease is not one. So I think it's time that we understand that all sleep apnea is not one. And very big and another important feature is there is this considerable bias on the profile that we have in our mind of a person who has sleep apnea. I mean, every now and then we come across people that, he doesn't look like a sleep apnea. No, he may not look, and especially women may not look at all because, they are much thinner. Sometimes they don't have so much snoring. So I think this has been really beautifully brought out. That's one part I wanted to emphasize, that all of us in this field need to have our thresholds very low and pick them up. Second, of course, she's highlighted beautifully that why is it so important? So why are we getting into all this? And I think for us as practical, I would say, is the approach towards treatment. So there is a lot of thought now that CPAP compliance is poor. So can you predict a poor CPAP compliance versus a good? And can you then be more armed and ready to handle these patients? So what she talked about, the fragmented or poor sleep, now we know it could be COMISA. And they are, yes, very difficult to manage. And so you should have some more time to manage these people versus these excessively sleepy people. They have one night of a good titration, they are very happy. And of course, the adverse outcome. So I think this is heading towards the precision medicine as it's talked about so much. But even if we can't measure the peak rate and things like that, I think overall, I would just take the essence is that we need to have a very good low threshold, think about the numerous types of manifestations, and then approach the patient and think that, why is it going to be difficult to treat? That's all that I wanted to say.
Yeah, I couldn't agree more. So, Sapna, I had a couple of questions to run by you. So, in the study that you showed in the beginning of your talk from Sri Chitra, did you have people who were above 75 who were also assessed, or were they all younger?
No, sir. We had age range from 30s to near 80s, actually, sir. We had older, like not many were there above 80 at that time because it was 10 years back. But now maybe if I look at it, I may be having more patients who are in the 80s now. Yes, sir.
Yeah.
We had.
So,
But our mean was less. It was around 53 only.
So, taking into account what Dr. Manveer Bhatia just very rightly pointed out, for a lot of people, I see a lot of geriatric individuals because of the nature of my practice. And I screen sleep health in everybody in a clinical questionnaire and assessment. And a lot of my individual patients with degenerative brain disease have also get a sleep screening done, either with a balloon or with a standard polysomnogram level 2 at home. And observationally, it's a very alarming thing to see what ma'am was pointing out too, is that they are lean, they are frail, their BMIs are 22, 24, 23.7, and they have pretty large numbers of apnea and hypopnea indices and have fairly significant oxygen desaturation as well. And many of them are not really, many of them are women, they're not smokers, they're not consuming alcohol, and they're pretty frail as well. So there is this gray zone of our understanding in the phenotypes of sleep disordered breathing, where in the elderly, perhaps just the sarcopenic frail ones are also sleep apneic, and we don't know much about it, simply because the global literature on this is also very modest. And I tried to look up all the literature on geriatric sleep disordered breathing. And there are a couple of studies from Italy where they have the same perception as what you pointed out, that in the elderly also, they may not complain of daytime sleepiness like you see in younger people for reasons not entirely well understood. But they just have declining functional abilities, and that leads them to go and see a physician. And sometimes it may be simple fatigue, not just daytime sleepiness. So what ma'am pointed out, I think it's a very relevant um, thought process that we ought to have in the clinic, that our antennas for picking up why is this person not able to function, what the contribution of sleep amongst the other things that we assess, should be a very important part of our assessment.
There's a question, Sapna. There's somebody's writing. What is the pattern of cognitive dysfunction predominantly in these?
Yeah. In OSA, what we get is usually it is not a florid cognitive dysfunction. You mostly get attention deficits and more of frontal dysfunction rather than other. But in any mild cognitive impairment, it is imperative that you should screen for OSA because it is eminently whatever component due to OSA is there, it is eminently reversible. So better. We also now pick up a lot of patients from cognitive clinic whenever they are screened for.
So even let me add in here that to answer that question, that there is an alternative way of looking at this. When I see patients who have cognitive impairment with an amnestic MCI, or sometimes a little more than an amnestic MCI, they are elderly. Now it is routine, and it's not just me, it's because I have been doing this for a while, but my colleagues in the department, Dr. Petroswadia, who also has a busy practice, we have been doing sleep studies in our cognitively impaired individuals. And I have now having a resident put together the numbers, but it looks as if almost a good 70-80% have moderate or severe sleep disordered breathing. And we really don't know what came first. Did the cognitive impairment come first, or did the degenerative process of Alzheimer-like deterioration lead to worsening breathing from involvement of networks that drive sleep harmony? Because we just had a student who did a thesis on PSP and Parkinson's disease, and we are right now writing the discussion. She has to submit it for her exam in the coming 3 months. So we live in very interesting times. I think every patient we see is teaching us something new.
Yeah. And it's just like egg or chicken, which came first, because
Yes.
sleep and cognition, they have a bi-directional relation.
Then I
So,
feel that whatever we can do, if it is even bidirectional or we don't know cause and effect,
but
if
we still have to
it's
correct it.
captured, maybe we can, because we don't have anything else, maybe we can decrease the decline, is what I tell people, you know.
So on the same note, there is a group in New York which runs a center called SAM, Sleep, Aging and Memory. This is headed by a psychiatrist called Ricardo Osorio, and there is a Nigerian American called Ominoga Bubu. You will find the largest series as his thesis subject when he was doing his postdoctoral PhD. And they have studied more than 300 patients, about 339 odd, if I remember, prospectively followed up sleep apneics, prospectively done amyloid imaging in the brain, and prospectively done cerebrospinal fluid A beta 42 oligomer markers. And a strong correlation between the presence and severity of sleep disordered breathing and the biomarkers and evident Alzheimer neurobiology in their brains. So some kind of confluence we will certainly see.
Yeah, definitely.
I don't think there's anything more than we can thank everybody for, and thank Sapna and the team, the IIN digital team and the participants. If the participants have still something, you can still write an email. Dr. Sapna's mail is there, or let us know. And actually, I was wanting to end with this, that whoever is joining now, I mean, you're welcome to give some suggestions, also to present a case. We are thinking we'll do this at least once in about 2 months, if not more often. So if you're welcome to present a case, then, we can just discuss the case. So feel free to write an email and let us know so we can all collectively take part in learning.
Yes, absolutely. And the other thing is that the sleep subsection WhatsApp group is meant for sharing thought processes related to sleep health and its relationship to neurology. So if you have things to share, that's also an active way of coming together and interacting on the group as well. So feel free to participate. Obviously, we don't want non sleep and non neurology data to be shared in any form. But having said that, this is a great forum, so we should all get together and enhance our interactive knowledge. And Sapna, thank you very much for accepting our invite to be with us and taking time out from a busy schedule to do this. Thank you so much.
Thank you, sir. Thank you for the opportunity.
Thank you. Thank you, everyone. Thank you.
Thank you, everybody.
Thank you.